The volume of chest CT scans performed annually in the United States is compounding rapidly, totaling over 12 million examinations. This surge is driven primarily by the rising uptake in lung cancer screening, or LCS, protocols. LCS is a standardized imaging procedure used to detect early-stage malignancies in high-risk individuals. Radiologists traditionally interpret these scans exclusively for the primary clinical indication, such as identifying a pulmonary nodule. By confining their analysis to a single, isolated diagnostic question, they leave massive amounts of objective health data entirely unexamined. The anatomical window captured on these scans, extending from the T1 to the T12 vertebrae, contains a dense, latent matrix of cardiovascular, metabolic, and musculoskeletal biomarkers. Extracting this latent data enables proactive primary patient prevention by measuring risks long before they manifest as clinical symptoms. Extracting these biomarkers requires strict algorithmic adherence to Hounsfield unit, or HU, thresholds. A Hounsfield unit is a relative quantitative measurement of radiodensity used to identify different tissue types in a CT scan. Cautionary tone. These HU thresholds are highly volatile. They are easily distorted by the foundational physics of how the scan is acquired. The primary physical confounders that corrupt quantitative data include variations in the scanner's tube voltage, the presence of intravenous contrast media, and the use of differing image reconstruction kernels. Without parameter-specific correction factors or dedicated normative reference datasets to adjust for these physical variables, the extracted data is clinically useless. We can systematically harvest this data through a guided compartment-by-compartment descent through the chest CT. The systematic multi-organ risk assay is becoming a necessary clinical standard, and its success depends on rigorous physical and algorithmic oversight. We begin this extraction sequence in the cardiovascular compartment, specifically targeting the coronary arteries. Coronary artery calcification, or CAC, is the strongest imaging predictor of future cardiovascular events and mortality. CAC represents the burden of calcified atherosclerotic plaque within the vessel walls. Traditional Agatston scoring relies on ECG-gated scans to freeze cardiac motion, but non-gated chest CTs yield diagnostically equivalent information. One constraint: non-gated scans tend to underestimate CAC scores by approximately 5% compared to gated studies. We overcome this underestimation by mapping the raw segmented scores against population-level reference percentiles. A patient's relative rank within these percentiles determines if statin therapy should be triggered. This calculator interface shows how raw scores are contextualized. The algorithm requires specific demographic adjustments for age, gender, and race to generate an accurate risk probability. Moving outward from the heart, we now shift our focus to assess the surrounding tissue of the lung parenchyma. This histogram visualizes the rigid threshold metric for emphysema quantification. Emphysema is defined precisely by the volume percentage of the lung that falls strictly below -950 HU. Here we also measure airway dysynapsis. This is an anatomic mismatch between the airway lumen diameter and total lung volume, and it serves as a critical early life marker for susceptibility to chronic obstructive pulmonary disease. In both the heart and the lungs, visual severity is highly subjective. Segmented quantitative thresholds dictate patient risk stratification with mathematical certainty. Transitioning down the z-axis, we arrive at a cross-sectional slice at the T12 vertebra level to assess global body composition. Body mass index, or BMI, is a flawed clinical metric. Because it only measures total weight relative to height, it fails to differentiate between protective muscle mass and dangerous ectopic fat. We isolate specific adipose compartments directly on the CT by applying a rigid thresholding filter, capturing pixels between -190 and -30 HU. Shifting the parameters to between -29 and +150 HU perfectly isolates the skeletal muscle area. Volume is only half the equation. We must also look for myosteatosis, the fatty infiltration of muscle. We measure this via skeletal muscle radioattenuation, or SMRA. SMRA is the mean attenuation of the muscle tissue and serves as a direct indicator of muscle quality. Body composition extraction faces a severe physics confounder: the extreme sensitivity of these specific HU ranges to the scan's initial acquisition parameters. This split-screen chart compares baseline metrics to a contrast-enhanced dataset. Intravenous contrast disrupts the readings, artificially dropping intermuscular adipose tissue area measurements by up to 9%. Similarly, routine changes in tube voltage between longitudinal scans can wildly shift adipose attenuation readings by as much as 21%. Without meticulous parameter matching across serial scans, tracking the progression of a patient's sarcopenia or obesity is mathematically invalid. Emerging calibration techniques using individual tissue attenuation characteristics are actively in development to correct this interscanner variability. Body composition metrics are powerful predictors of hospital length of stay and mortality, but they only function if the physicist or the AI accounts for the exact parameters of the contrast phase. Our final anatomical stop zooms in directly on the central core of the T12 and L1 vertebral bodies. Dual energy X-ray absorptimetry, or DEXA, is the current reference standard for assessing bone health. However, routine CT trabecular bone attenuation performs with comparable accuracy for fracture risk assessment. The methodology for extraction must be precise. An oval region of interest, or ROI, is placed exclusively in the anterior trabecular space, strictly avoiding the dense cortical bone and the posterior venous plexus. While the L1 vertebra is the gold standard target, T12 serves as a highly reliable proxy. Measurements between the two differ by a minor 5 HU differential in diagnostic cutoffs. Bone attenuation is also vulnerable to physical confounders. IV contrast blood pooling artificially inflates trabecular attenuation, which can mask osteoporotic degradation. Image reconstruction filters pose an equal danger. Applying a sharp kernel can artificially alter bone attenuation values by a massive 10%. Diagnostic thresholds for osteopenia must be dynamically calibrated against both the specific tube voltage and the contrast phase used at the time of acquisition. Bone attenuation provides a highly accessible metric for surgical planning, provided the algorithm explicitly filters out cortical boundaries and accounts for the reconstruction kernel. Pulling back from the microscopic tissue view, we must look at the chest CT volume as a single massive data block containing hundreds of cross-sections. It is impossible for a human radiologist to manually threshold, segment, and correct physics parameters for these 5 domains within a modern clinical workflow. Opportunistic screening relies entirely on deploying FDA-cleared AI platforms to automate this exact extraction pipeline in the background. Even with perfect AI extraction, a raw number like 122 square centimeters of muscle is totally inconclusive to a referring primary care physician. We must apply allometric scaling. Allometric scaling is the mathematical adjustment of anatomical measurements relative to a patient's body size, such as dividing skeletal muscle area by height. These scaled metrics must then be plotted against rigid, population-level normative reference values to determine true clinical deviation. Crucially, these reference values must be strictly segregated by age, sex, and race to avoid misclassifications of disease risk. The final radiology report translates raw Hounsfield units into actionable, normalized percentiles to ensure the data is useful for primary care providers. Mastering the physics of thresholding and the algorithms of scaling reveals the high-fidelity clinical insights embedded within millions of routine scans. Opportunistic screening creates a comprehensive quantitative map of a patient's future health out of a single diagnostic scan.